Okay, I think we'll get started. Welcome, everybody. Again, I'm Mike Saag from the University of Alabama at Birmingham. This is a workshop on resistance. And historically, the way I've done this is I just basically said, okay, we all know resistance happens. What are your cases? And I realize that a lot of you may be new to the field, and some of you who've even been at this for up to 10 or 12 years really haven't encountered resistance the way that we used to in the old days. So what I'm going to do is I'm going to take about half the time, maybe a little bit more, to give just like a mini lecture on what is resistance and how does it go, just to make sure everybody's on the same page. And then I'll stop and we'll have question and answer. And I think that'll fill up the hour pretty quickly. So just going to be mindful of the time and we'll get started. So my institution has received research grants from Gilead and ViiV that I've been the PI on. So let's go back to basics. First off, remember that anytime we're using antiretroviral therapy, we're stopping the life cycle of the virus in some sort of way. And that intervention can be at the level of reverse transcription, as you see in the middle here, integration, where it goes into the host nucleus, or maturation in the case of protease inhibitors when a virus buds out of the cell and then needs the protease inhibitor activity to make that virus uninfectious for the neighboring cell. And the take-home point of this slide is that all antiretroviral therapy can do is prevent an uninfected cell from becoming infected. That's it. As Dr. Silicano just went over, we can't easily get rid of cells that have already been infected. So the story I'm about to tell you came from this one graphic. When we were working with Integrase in September of 1993, we were one of the first to do it because we had access to viral load before it was ever really mainstreamed. And this is what we saw in one patient on monotherapy. So my first question to you guys is, and you don't have to answer this in a poll, just how many virions are produced a day in an infected person? So go ahead and think about your answer. And when I've done this before, a lot of people guess low numbers. Some people are guessing how many virions produced a day. It's actually well over 1 billion viruses produced a day, well over a billion viruses. And it's usually 1 to 10 billion. So I think we'll just move on from that because I want to make sure I get to the other part. But that polling worked well. Thank you. I like that. It tended to work very well. Appreciate it. So this was a study that was published in Nature in early 1995, and this is the story it told. So you have HIV-infected cells that are in the body. We just talked about them. And we also have a large number, vast majority of cells are resting uninfected CD4 lymphocytes, but a very small fraction, less than 1%, get activated. And it's the activated virus, the cells that are susceptible to viral infection. The ones in yellow generally can't get infected because of something Dr. Silicano alluded to. It may have gone right past you, but ApoBec3G protects these cells from being infected. And so these cells kick out collectively about 1 to 10 billion viruses a day. They come down, they selectively infect these guys, and this cycle continues day after day after day after day. Such that these 1 to 10 billion cells. And then the question is, well, how long do the infected cells last? And the answer is about a day. So when we give antiretroviral therapy, what we're doing is we're blocking those uninfected cells from becoming infected. And when they do that, the cells above them may die off, or some of them, very few, go on to form that latent reservoir that Dr. Silicano so eloquently just told us about. And this is a normal state of HIV replication. And the cells that we're actively producing, as I mentioned, live on order of a day. That's about it. So when they go away, they're not replaced anymore under the conditions of antiretroviral therapy, but that latently infected reservoir still exists up here in the upper right-hand corner. And all of that, believe it or not, was described by that one graph I showed you, which I think is pretty remarkable, working with Martin Novak, who at the time was at Princeton and a mathematical modeler. Now, a second study that I think is very important is looking at the amount of virus in the plasma and relating it to the number of cells in the body producing virus. So each of these lines are pre and post antiretroviral therapy. The viral load in the plasma was easy to get just by blood draw, but it's comparing to lymph node biopsies that were done pre-therapy and then somewhere between 4 and 6 months later when the viral load had dropped substantially. And you can see from the back of the room that there's a linear relationship between the amount of virus in the bloodstream and the number of cells producing virus. That's a critical concept that I'm going to come back to as it relates to resistance. So now we can see if we can get this pole up. At steady state, when an actively producing cell dies, it is replaced by how many infected cells? Go ahead and vote. Okay, you guys are doing good. Let's see what the results show. And so the majority of you said it depends on the viral load. The actual correct answer is number 1. 1 is the loneliest number. And remember, the active term here is at steady state. So if viral load is directly proportional to the number of cells in the body, at steady state, when the viral load is, say, at 30,000, those cells producing the virus die in a day, and they're replaced precisely by 1 to take its place to maintain that relationship between the viral load and the number of cells in the body. That's a critical thing to understand when it comes to how resistance develops and how viral load actually works. And there's the poll. Okay. So this looks like a kidney. It's actually a lymph node. Somebody asked a question in the last session about where does the replication take place and where are the reservoirs. It's mostly in lymphatic tissue. So here's a lymph node. And if we go to the paracortical center, you can see, using the same color scheme that I had before, the majority of cells in that paracortical center, those T lymphocytes, are uninfected and unactivated. And every now and then you see an activated cell. So if the viral load is 100,000, it's not too hard to see where the cells are living inside that lymphoid tissue, because there's a lot more cells because the viral load is high. But if you have a viral load less than 50, it's like, where's Waldo? You got to look pretty hard to find that one cell or so in amongst the sea of other cells that are not infected. But if we bear down a little bit more to the micro level, here's what's happening when people are not on antiretroviral therapy. You've got a cell in the center here, the blue one with the integrated virus, that's kicking out, we don't know how many viruses precisely today, let's just say several thousand or maybe a couple tens of thousand, and it's kicking that virus off, and those viruses go out and spill into the bloodstream where we can detect them. But notice in this cartoon that it's surrounded by a lot of yellow cells, which are the unactivated T cells and really aren't targets at all for infection. So this thing's trying to infect, much like Will Ferrell in Night of the Roxbury, just trying to send out their vibes to see if they can get somebody who can play with them. But here comes an activated T cell. So that's maybe the drunk person at the bar who's susceptible. And here comes that vibe, it's coming out, here comes a virus. It infects that activated cell in the neighborhood. And what's remarkable, that happens at precisely the time, on average, at steady state, when that other cell dies, because that cell in the middle is going to live only about a day, and it takes about a day to find that new cell to become infected. And that's what happens. So when we give antiretroviral therapy, if that activated uninfected cell comes by, now it has a force field around it, such that when this virus kicks out, it can't either enter the cell because of a entry inhibitor, or it can't undergo reverse transcription, or it can't have any kind of way of becoming infected. And so when the center cell dies, the viral load comes down precipitously because that cell in the middle dies in about a day. And when the other cell is not replacing it, then because viral load is proportional to the number of cells in the body producing virus, that viral load drops. So it can infect, and there you go. And all that, again, came from that one story. Now, let's transition to resistance now that we have this understood. And let's take the example of nevirapine monotherapy. Remember, nevirapine is a non-nucleoside drug, has a low barrier to resistance, which we'll get to in a minute. Well, when there's a low barrier of resistance, that means that one single point mutation can lead to susceptibility of the virus. Again, it can fight through the effects of the drug. So in this case, I'm representing this as a picket fence rather than a full force field surrounding the cell. And so in the center cell, we have it kicking out a lot of viruses. And we know that there's a mistake made in the 9,000 base pair HIV. When it replicates, there's a mistake made every 4,000 to 5,000 base pairs. So that means that every time a virus is kicked out, a mutant virus is likely to come out among the many. Oftentimes that mutation is not something that leads to a change in the virus's function or the proteins produced, but every now and then it does. So let's say by chance that the center cell kicks out a virus that has, by chance, a reverse transcriptase mutation of position 181. So it's a Y181C. That means that nevirapine can no longer block that. So now the cell in the upper right-hand corner becomes infected with a virus that has a Y181C. And what that means is that once that happens, the cell in the center, the cell in the upper right-hand corner can now be infected. And when that center cell dies, now that upper right-hand cell that's infected with a virus that has Y181C, every virus it kicks out now has Y181C. And that happens so fast that a study we did back in the 90s showed that within 3 days, you can detect in the population of viruses that are Y181C. By 14 days, half the population is Y181C. And by 28 days, the entire population is taken over by Y181C. Remarkable speed of replication, and it shows you how quickly resistance can happen, which is why we harp on the notion of making sure people maintain their virus for as long as possible. So the question I see coming in is, how long does the virus live in the bloodstream? The bloodstream is basically a spillover. So it's going to go in, the virus will come into the bloodstream, circulate around, and then it'll be absorbed off by one of the lymphoid tissues or bound away. So when you have really active viral replication going on, lots of cells in the body infecting, kicking out a lot of viruses, the viruses in the bloodstream are simply a way station, just simply a highway, super highway, and there's not much, the virus doesn't stay there long, it's cleared pretty quickly, and importantly, very little, if any, replication occurs in the bloodstream at all. All the replication, all the action is in the lymphoid tissue, the sort of train station I alluded to earlier with Dr. Silicano, where the cells come in to kind of take a break, meet up with their fellow cells and talk to one another. And also if there's an infected cell there and there's an activated cell nearby, it'll just infect that cell. This is the HIV genome. You can see it's broken down into different regions. And the key region for us is the so-called pole region in the center. And it has different components that code for a protease. There's a center component that codes for reverse transcriptase. And there's another component that codes for integrase. So all the action for most of our antiretroviral drugs is in that region. So any mutation that might occur in that yellow 2900 base pair fragment, that's where resistance happens. And so I've already alluded to Y181C. You're probably wondering if you're new to this, what in the world that means. What it means is in the reverse transcriptase coded region that goes from 1 to 560 different codons, there is a position 184, there is a methionine that's replaced by a valine. It's replaced by valine. So when you have the nomenclature, the wild type is on the left, and the mutant that it changed to is on the right. So you have M184V, and that's how these go. And so you have to go back to remember what are the proteins that are coded, and they're all listed for you here. And you can get all this information on the IAS-USA website. And there's a link. We're going to get these slides to you so you can look through them. And then also the IAS-USA sponsors drug mutations activity that keeps the mutations up to date. There's also the Stanford database. It's a great place to go and look up, plug in your mutations and figure out what's what. But on the IAS-USA webpage, here's an example of NRTIs. We're going to get to some cases about that in just a minute. But you see on the right-hand side that there's a M184V present, and that's the far right that leads to resistance somewhat to abacavir, but for sure FTC and 3TC, et cetera. For the NNRTIs, the one we know have heard about the most is for efaviren's at K103N, sort of in the center there, and et cetera. Here's the Y181C that I mentioned for nevirapine a little earlier. That's a very powerful mutation for most of the NNRTIs. Notice at the top, doravirine, the newest of the NNRTIs, is mostly resistant to resistance, if you will. It's harder to knock down. The PIs are a little bit more complicated because it usually takes multiple mutations in the genome. The exception might be the I50L mutation for atazanavir, but the rest of them require multiple mutations for them to be taken out. And so you get shades of gray in terms of the activity of a drug, even when a resistance mutation is present. And then we see the integrase inhibitors. They also have resistance. It's mostly concerning for elvategravir and raltegravir, where a single change of position 148 knocks it out. The other ones, dolutegravir and cabotegravir, which are cousins of one another, basically the same drug, cabo just being a longer acting drug, and bictegravir have very similar profiles. And if you have a Q148H present, where it would knock out completely, more or less, the elvategravir and raltegravir, dolutegravir could be used and given twice a day at 50 milligrams instead of once a day. So what about resistance testings? In general, as you know, the guidelines recommend a genotype as part of the screening before ART is started. Following failure of a first or second regimen, we still recommend a genotype. And even though you may not be familiar with interpretation of this, you can go to the Stanford website and plug in the mutations that you're encountering, and it will interpret with you how that's done. And of course, you should always be able to phone a friend, somebody who you trust who's an expert in the field, who can help you work through resistance mutations. After the third or subsequent failure, it's a little bit more difficult. And this is especially true for the protease inhibitors, which I mentioned have shades of gray. But a real expert can look at a genotype and kind of deduce or divine what might work. But the phenotype actually helps. And the phenotype is basically like what we use in antimicrobial therapy. It's infecting a cell with prototype and then trying to grow virus under the presence of the drug or not, and looking at a curve with different concentrations of the drug, and I'll show you an example. What if there's discordance? And that happens sometimes. Generally, people default to the genotype, which is a little bit more sensitive, although they can get complicated, as I'll show you in a minute. And finally, resistance mutations accrued from an earlier regimen may not be detected from the plasma at the time of a current failing regimen. So in other words, somebody could have been on 3TC in the past and developed a M184V, but now they're on a regimen that doesn't have 3TC in it anymore. So that virus that's in the regimen that's failing currently may have a wild type M184 thing, but that doesn't mean that, as Dr. Silicano just showed you, there can be archived virus in the latent reservoir that, given the chance to be re-expressed, if you gave 3TC back, it could reselect for that hidden reservoir. So you still really need to know you still really need to know what the prior genotypes were and what the prior regimens were for that matter. It's a very important thing. We have a question that's coming in. So do you recommend prior integrase inhibitor testing prior to ART? No. There's so little integrase inhibitor resistance in the community that that's not advised. Is there a rare situation when that happens? Yes, but it's very, very, very uncommon. And so the policy would be not to test for integrase inhibitors. So here's everything you need to know about nucleoside analogs in one slide. And I'm not going to dwell on it because I'm going to get these slides to you. But the M184V we've already talked about, or it could be M184I. The TAMs, which are for nucleosides like our AZT-like, can increase susceptibility to some of the other agents, such as TDF. There's a couple of pan-resistant nucleosides that we don't see anymore because that was mostly an AZT, DDI, D4T sort of issue. We don't really see these 69 insertions anymore. K65R, we're going to talk about a little bit more in just a minute. And there's a few other rare mutations, but we don't really use AZT or D4T much. So these are mostly for historical purposes. So here's a phenotype, and it's with, as you can see, a single M184V. And what you'll notice is that the gray bars are showing that at the top, reduced susceptibility for 3TC and FTC, for lamivudine and emtricitabine. But notice that abacavir takes a little bit of a hit, even though it's still blue, which means susceptible or relatively susceptible. You see the cutoff for abacavir at the top is somewhere around 6, and this has now been kicked out to about 3.5 to 4. So it's got a little bit of a hit there. But maybe more importantly, when an M184V is present, you get hypersusceptibility as indicated under stavudine, zidovudine, and importantly, tenofovir, where the drugs are actually working a little better than they do against wild-type virus. So that's kind of an interesting concept. One of the questions coming in is archive testing useful? It can be if you've got a very, very advanced retroviral experienced patient for whom you really aren't sure what's going on. It can help, but there you're looking for the intact virus that Dr. Silicano was talking about and to do a sequence of that. And that was the same question as the proviral DNA. I personally don't use them very much. I find that I can kind of get to the right answer with the genotype of the present therapy and looking at their antiretroviral history. So let's go to a question. The genotype shows M184V and a K65R. They're both present. Which NRTI would you include? And there is one correct answer here, and the other 3 are wrong. Go ahead and vote. K65R. Okay, looks like a lot of you are still with me and awake. That's good. I see a lot of answers. I'm going to end the poll and share the results. And I'm afraid here again, we got mostly the wrong answer. The correct answer here is zidovudine. K65R is the Achilles heel of tenofovir. And it doesn't work very well when there's a K65R present. And here we go. This is going back to the nucleosides, and you see for tenofovir, that's its main lesion. We don't see a K70E very often, if at all, anymore. It was usually caused by DDI therapy or, sorry, D4T and that type of thing. So we don't see much of that anymore. Here's another example of where you get, here you can see increased susceptibility by zidovudine when a K65R is present. That's really kind of important to know. So if you encounter that, you're going to probably lean away from using zidovudine. One other quick comment I should have mentioned earlier, with an M184V, those who are thinking about using dolutegravir with 3TC in that single combo pill, you got to make sure that there's no M184V, because otherwise you're basically using dolutegravir monotherapy. So we'll get into that in the case discussions a little bit later today. So non-nucleoside mutations, here you see them, K103N for efavirenz, Y181C. The important concept here is this thing called low genetic barrier. What does that mean? It basically means if there's a single mutation, you can knock out the entire drug. Just a K103N knocks out efavirenz. A Y181C knocks out nevirapine. So that's low genetic barrier, as opposed to, say, protease inhibitors were multiple hits, or the newer NNRTIs, etravirine, rilpivirine, doravirine, you have to have more than one resistance mutation. And interestingly, K103N, that etravirine can still work, and to some degree, so can doravirine. And here you can see the drugs. Again, they all have some prime mutation, but you notice that for rilpivirine, etravirine, and doravirine, there are fewer resistance mutations that you have to worry about. And so for protease inhibitors, I've already said this, it has a higher barrier of resistance, higher genetic barrier. The I50L for atazanavir, but otherwise it takes more mutations to cause problems. And here's you can look at this on the IAS-USA website. Let me pause for some questions. I want to echo the question about archive tests. We've used it a couple of times and found it to be confounding. Yes, I don't use it very often. So it can be quite concerning. Another question, can you explain fold chain? Yes. So what it means is that it's like how much more drug is required to inhibit the virus. Twofold, threefold, fourfold, fivefold, et cetera. So it's really a question of how much more drug is required to inhibit the virus, and that's what's happening there. And is there a difference resistant profile seen with TAF and TDF? No. TAF and TDF are basically pharmacologic differences where TAF is more efficient in getting absorbed and then getting into the cell. Remember, the replication is occurring, the activity of reverse transcriptase inhibition, like you get with tenofovir, is inside the cell. So TDF just requires a higher drug level to get into the cell than TAF. So it's 300 milligrams versus 25. But once it's inside the cell, the concentrations of the active component tenofovir is the same, and that's really what resistance is about. It's not really about TAF or TDF. So here's a mess, right? This is an older, you can tell it's older because look at the protease inhibitors are here. We don't even have darunavir, but it shows you, look at the protease alone, you got mutations of 10, 20, 46, 50, 54. Sounds like the beginning of a football play with the quarterback calling signals. And the bottom line is you can see variation in the fold resistance of the different agents here. And I think the take-home point here is that maybe with just a 12 or 13-fold or 20-fold indinavir may work a little bit. But since this is old, let me give you something a little bit more modern. This is equally scary because now we're working with a highly drug-resistant virus that, especially the protease inhibitors, just the whole class, except for perhaps tepranavir. But we don't use much tepranavir anymore because of the toxicity. But this person's in trouble, and this would be someone we would call have multi-class resistance that Dr. Gulick talked about in that latest study, and I'm going to show you some more data here. A question coming in about the difference between genotype and phenotype. The genotype is simply looking at the genetic sequence. So it's looking, is there a position at 70, in this case, for NRTIs, at 74, 75, 115, 184, 219. Those are specific parts of the genetic structure of that RT polymerase. What's changed? The phenotype, which you see in the bars on the right-hand side here, the phenotype is about just, it's like a functional assay that looks at the activity of the drug when run against the production of virus and how much drug is required to shut the virus down. And here you can see that for the most part, it takes a lot of drug and in a lot of cases unachievable from a pharmacokinetic standpoint. So let's go to another question. Which of the following mutations leads to high-level resistance to elvitegravir? I've already given you this answer, but don't feel bad if you miss it. That's the reason I'm asking it again. Go ahead and vote. Okay, looks like most of you have voted by now. And yay, people were listening. Q148R was the main mutation, and as I mentioned, it kind of knocks the whole drug out because in that case, the genetic barrier was bad. I'll get to what I'd recommend for that awful situation for that last patient at the end of the talk. And let's shut that off. So these are the integrase. Again, you can go to the IAS-USA website and get this exact thing. And I've shown this earlier. But again, as I mentioned, for dolutegravir, bictegravir, cabotegravir, the changes you can usually get through. But the problem with bictegravir is it's co-formulated with TAF FTC. So you can't really go to twice a day without overdosing on the TAF and the FTC portion. Cabotegravir, as you know, is injected, so it's also fixed. So your out here is with dolutegravir given twice a day if there's a Q148H or R present. So coming to the end at this point, we'll have questions for the last 15 minutes or 20 minutes or so. This is a study that we did in what's called the CNIX cohort, something that I'm involved in. And we looked at people with what we called limited treatment options. So if you go back to 2000, about 6 to 7% of folks had limited treatment options. And as we got more experience with some of the newer agents, it just didn't help. You'll notice in 2007, there was a dramatic drop. And why was that? Well, because raltegravir got released. So the integrase inhibitors came onto the scene, and that's been the game changer. And as we've gotten better with more widespread integrase inhibitor use, you'll see that the chance of someone being in trouble like that horrible phenotype I showed you a little while ago, that is a rare phenomenon now, less than 1%. And independently, the study that Trip Gulick showed from the IAS meeting totally confirms exactly what I'm saying. And this study is now in press, and AIDS will be coming out in the next month or so. So that's a very exciting development, and it's good for all of us. And if you think about it, as I said at the beginning, if you started taking care of HIV patients in 2010, you aren't seeing a lot of resistance that's hard to manage, right? It's unusual to get to that point. The people who are having the most trouble now are the people who started on therapy, let's say in 1990, and went through a lot of the drugs as they came out, and the regimens failed when they went on to the next, and they got some carry forward resistance. That's been something that we've seen. I'm going to finish up here, and then I'm going to get to the questions. If I can. Oh, there we go. And what's remarkable is that even in that 1% who had limited treatment outcome, limited treatment availability drugs, once they got put on the new regimen, they did as well virologically, despite having limited treatment options, as those who didn't have limited treatment options. That shows you how far we've come in terms of managing high degrees of resistance with newer agents, and some of them might include not just the protease inhibitor, integrase inhibitors used twice a day, perhaps finding a couple of the nukes that still work. We got fostemsavir that's now available that could be added in. Ibilazumab, which is the IV one, could be used. It's a blocker of entry, et cetera. So those are the things as we know it. So let's go to the questions and answers. I hope that for those of you who've done this a while, I apologize for the basic review, but I think a lot of you are new to the field or newer to resistance. It's a question we get every time we have one of these clinical conferences. People say, I wanted to hear about resistance, and so here we are. That's what I thought I would cover. So in the time we have remaining, let's go to the question. So what's the current thinking about replication capacity and the presence? That's a great question. So what is replication capacity? It means in the presence of the drug and the mutation might harbor some inability of the virus to replicate. So it could be a critical mutation that just impairs the ability of the virus to function. And so with an M184V, the virus can still replicate okay, but not great. And so what we also found is that despite the fold change that you see on the phenotype with M184V, in the presence of M184V on lamivudine monotherapy, a study done by, I believe it was Joe Aron at UNC back in the mid-90s, you still saw about a 0.5 to 0.6 log reduction, even in the face of M184V, when lamivudine was continued as monotherapy, which we don't do anymore, by the way. But that's something you could still see. So it's not harmful. In fact, I think there's some benefit to adding FTC or not both, or 3TC to a regimen as you're trying to rescue folks. And it may be the replication stuff. All right, so what would I consider for that patient? I would lean towards things like ibalizumab. I would use dolutegravir twice a day. We didn't have an integrase inhibitor resistance mutation present, but if there's no mutation, or platinum, because that guy can be rescued pretty readily. If there is, then you got to use twice daily dolutegravir, the ibalizumab, as I mentioned, fostemsavir if you can get it. Usually one of the protease inhibitors, especially darunavir, and it can be given twice a day, can be helpful. Here's the irony. In my experience, and I bet yours as well, the patients who are coming in with that kind of genotype or phenotype are the ones who, for whatever reason, had trouble keeping up with their regimens, even when they were simple. So now to treat them, we've got to go to twice daily XYZ, all kinds of more pill burdens. And so that makes it even tougher. I will say that in my experience, and we have about 3,500 to 4,000 active patients here at our clinic at UAB, this is a rare phenomenon. I can count on one hand or less than 5 fingers the number of people we've encountered in the last year. Still, it can be a problem, and that's what you have to know. Question about, can I use ibalizumab in end-stage renal disease? I do not know. I'd have to look that up. Being fairly new to HIV, difficult time building a regimen of the patient multiple resistance, some guidance on what you would do to help. Stanford database. That's a great place to go. It's referenced, I think, on the IAS-USA website for sure. It's also in the IAS-USA guidelines and a reference. But go to the Stanford resistance database, and it allows you to plug in, type in the resistance mutations, and it will tell you which regimens should work, which drugs should work in that setting. So that's pretty exciting. Next question is there any evidence of contribution of resistance in a positive patient who's exposed to another? Can you super infect someone with a resistant virus? Not really. I'm sure there may be a case or two, but for the most part, there's not much transmission between people. And if the drugs are on board, it's usually enough to abort an infection. But also, and this is more hand waving, almost literally, when somebody's been infected with HIV, a lot of the docking stations, the places where a virus can establish an infection, are kind of occupied. And so super infecting someone is a hard thing to do. I won't say it's impossible, but it's not common. So it's rare that we'll see somebody who's suppressed, who had an exposure to someone who, let's say, had a high level of virus and there's a lot of resistance in that person. Could it transmit to them? Yes, theoretically. But I don't think it's likely at all. I've inherited several patients with multiple drug regimens. Simplification comes up. The majority recall their history. They don't recall their history of resistance testing. Yeah, that is a common problem. Most of the cases that I've seen like this were exposure to a lot of drugs going back to 1995 or maybe before. I have gently moved towards going to a more simple modern regimen. The patients are nervous about it. I'm nervous about it. But I think if they have not had an integrase inhibitor before, I think it's a pretty safe thing to do. If you have data, great. If you don't, it's just an art. I can't describe it any better than that. It's an art of therapy. And so it's really, really difficult. And you got to do it cautiously. When I do that, I bring them back about every 2 to 3 weeks for a repeat viral load, just to make sure they don't start to spike. And if I do see a spike, then immediately I'll grab a resistance assay, revert them, then on that visit, revert them back to what they were on before, and then try to work through it with some better data in hand. Yeah, do you mind unsharing? I think they did that for me. Is it in a serodiscordant couple and the HIV person's resistance pattern in selecting a PrEP? If the seropositive patient is undetectable, you don't have to worry about it because there won't be transmission. And the reason for that is there's a critical value of how much virus needs to be expressed in the seropositive partner for transmission to happen. The hint from a Rakai study back in by Tom Quinn in 2000 of serodiscordant couples before there's antiretroviral therapy found that 1,000 copies per mil or below, there was no transmission. Now, can you translate that to today? I wouldn't feel comfortable, first off, watching a patient walking around with 1,000 copies per mil. I'd have them on treatment and try to get them at least less than 200, which we can do readily these days. But if the seropositive partner is less than 100, is certainly less than 50, you don't have to worry about it because there's not going to be transmission. For patients with M184V who are on TAF FTC, do you make any adjustments? No, especially when their third agent is highly active, like an integrase inhibitor. There's been multiple studies now that show that, and I believe one of our questions coming up in the case presentations will allude to that. So in a pregnant patient who develops a Q148R on raltegravir, can dolutegravir be given? I think so. I don't know. I'd have to look at the PK. The biggest concern in pregnant women oftentimes is that the placenta and other situations of pregnancy lower drug levels. So I think going to twice a day dolutegravir might be okay, but to be honest, I don't know the answer to that. Fortunately, that situation is uncommon, but I would talk to an expert in pharmacokinetics or maybe check with a drug company about their data. Remember, the dolutegravir use in pregnancy, we're just getting the data. Dr. Gulick covered a lot of that in his presentation earlier today. I'm going to go into that again later this afternoon, but I don't know about safety of twice daily dolutegravir there. Ideally, I would probably use a protease inhibitor in that setting, at least during pregnancy, and then you can think about other things at that moment. Am I rapidly starting treatment-naive patients on the combination of dolutegravir 3TC, the single drug regimen? And the answer is generally no. What we've been doing is starting on a 3-drug integrase inhibitor-based regimen, checking the resistance before we start that regimen. And then if we see that they were wild type and they don't have an M184V, then you can switch them pretty quickly to dolutegravir 3TC, especially if the other ideas are favorable. If you want to roll the dice and you think, oh, heck, I'll just throw this at them and wait for the resistance to come back in a week, you could do that. The chances of 3TC transmitted resistance depends on where you live, might be up as high as 5%. So you're taking risk on the 5%. And you're also assuming that during that acute phase of drop that there won't be emergence of dolutegravir resistance. And that's probably true, but there aren't any data. I think it's just safer. You want to use dolutegravir, just use dolutegravir. You can't use it with abacavir because you want to get the ALA B5701 before you use that. So you probably would be using dolutegravir as one pill and then either TDF, FTC, or TAF FTC as your anchor for the nucleosides. Wait a couple weeks, get your genotype back, and then you can switch over to the fixed dose combination dolutegravir twice daily. And do always check another genotype on a regimen. For treatment naive, yes, always. That's something that the guidelines are recommending. We can have more questions in the chat if you'd like, or if you just want to shout out a question, we can do that. We have a few minutes left here before we'll wrap up. Or if you have any other cases that you wanted just to kind of run by. I think we've hit a couple of the really tough ones for sure. The notions of those patients who come in with a prior history that's quite complicated. So I know many providers who are ordering a viral load test that reflexes to genotype of greater than 500. There may be yeah, I think that's decent. I don't have that ability, but I think it makes sense. The only problem, you got to make sure they're on their regimen at the time the genotype is taken. So someone who, let's say, stopped their regimen for whatever reason 3 months ago, and they come back now with a viral load of 20,000, that genotype isn't going to be as helpful as it would have been had they been on their regimen, the regimen's failing, and then you get a genotype while the viral load is detectable. So as long as you understand that that's a bit of a risk and maybe overutilizing a genotype, okay. But we don't do it because I don't have the ability to do it. Would I do it? Maybe, as long as I had the option of canceling that reflex if I knew on that visit that the patient hadn't been on therapy for more than 4 weeks. Guidance about the difference between med failure and a high blip. Great question. We're going to go over that in the cases in a minute, but to give you a preview. So a blip by definition is an increase of detectable virus when it had previously been suppressed, let's say below 50. And typically a blip never goes above 200. If you see a viral load above 200, it's most likely that patient's missed some doses of medicine in the time preceding. And if they come in, I'll talk about adherence. And if I see the blip, I'll call them and say, hey, were you missing some doses before you came in? Why don't you try to go back on your regimen, really be good about adherence, come back in 3 or 4 weeks where we check you. And at that time, at that point, I will also order a genotype just in case it is true failure, especially if they tell me they hadn't missed a dose. I'll bring them back that week and recheck the genotype, the viral load and the genotype to confirm. But it's usually that threshold of 200 copies is where I'll start getting concerned about it. Where does a blip come from? Well, Dr. Silicano just told us in her last lecture. We know that resistant virus exists inside of a latent pool. And if that, even without de novo replication, even without, the antiretroviral therapy is working, if you have a pool of cells that are infected with latently infected virus and they get stimulated, they'll start spitting out virus. And if that reaches a critical amount, then that'll spill over into the bloodstream, as we talked about earlier, and you can detect it. That's what a blip is. It's not an indication of virologic failure per se. During COVID, for patients out of care and returning, would I feel comfortable rapidly starting, if no concerns and history of less than 200 via telehealth and having close follow-up? Interesting question. It depends on the situation. I don't mean to punt, but I typically like to start therapy on people face-to-face because it's an easier way of reading their body language, are they with me? And we can develop a little bit more rapport. Are you doing something horrible if you do it that way? No, I don't think so. But I think optimally, I would have that person come in before I started, especially initial therapy, where you really are trying to develop a rapport. So Dr. Wong has raised her hand. Go ahead and unmute yourself and ask a question.
Oh, sure. I'm a nurse practitioner, actually.
Okay, fine. With Dr. Wong.
So I have pregnant patients. She just came from Ghana. She was pregnant. She's on she's on Synfig right now, so she's undetectable. Like a viral suppressed, like a viral load is 80. So her resistant test just came back. She's resistant to like a lamivudine and trazodone as well. So my question is, because I know in the previous presentation, we should change to integrase inhibitor would be better, like dolutegravir. So my question is, should I keep in the previous current regimen right now, or should I switch to a regimen?
Yeah. So you said her viral load is 80. Is that right? 80.
Mm-hmm. Initially, when she came back, was 190.
Okay, I'd say she's doing okay. I might check it a little bit more frequently. Could you switch her safely? Absolutely. Remember that the neural tube forms in the first 6 weeks of life. So the baby is well past that danger zone, if you want to call it, for a neural tube defect. And that's why Dr. Gulick was so careful to say at conception versus during pregnancy. So if you think that you're concerned about that it may be going back up or something, I think you could switch safely to dolutegravir. I think that'd be fine. We don't
take off the Efavirenz and the Centuza?
Yeah, I would switch her. I would probably switch her completely to a 3-drug dolutegravir and 2 nuke regimen, unless there's a lot of resistance to the nukes. It's probably, but I think you're actually okay staying where you are, to be honest with you. I don't consider 80 virologic failure, personally. I think it has to be above 200 and consistently above 200 for me to call that failure. It's a judgment call. Yeah.
Well, what about side effect? Were you concerned? Because in the presentation, I'll talk about side effect as well, comparison to that and dolutegravir.
Yeah, side effects would be a great reason to switch. I mean, I don't think I'd want to take a boosted anything personally, and we'll talk about that in the cases in a little bit too. But yeah, if you're having a problem with that, if the patient's having a problem, yeah, switch her. Absolutely. We're not trying to torture people, right? With antiretroviral therapy, we should be able to find a regimen that has virtually no side effect if we keep working with them. Other questions here are concerned with viral load in 220 to 200-ish. No, as long as it stays below 200, and it's rare that I'll see anything persistently above 100. You see it sometimes go up and then come back down. Usually I've seen a lot between 60, 80, 85. That doesn't bother me as long as it's consistent. You could check them more frequently if you're worried about that. And yes, take that as an opportunity to reinforce adherence, because sometimes there is intermittent adherence. And that's where resistance can emerge, is when the drug levels are creeping down. It's just like with antibacterial therapy. If the level goes down that allows replication to some degree in the face of drug pressure, the likelihood of selecting for a mutation becomes higher. Some of these things with higher barriers of resistance, like integrase inhibitors, dolutegravir, bictegravir, not very unlikely to happen, but it could. I think we have time for maybe this one more question here. With NRTI resistance, I've been doing a PI and INSTI. Do you worry about boosters? A little bit, but that's an okay approach. A lot of people have used, with very little data, dolutegravir and boosted darunavir, and sometimes they throw a little 3TC on board just for a crouton on the salad. That can work. The boosting is more an issue of tolerability. And sorry, we had one more that just came in. Sometimes our lab messes up when we order a genotype prior to initiation. Then when I see the patient a month later, I can order, but the viral load's less than 500. You could try it, but the reason that 500 cut point is there is because the technology of doing a genotype is that you take the virus and you PCR amplify it to large numbers, and then you do a genetic sequence of that region and read it out. If you can't amplify, then you can't do a genotype. And typically you need at least 500 copies on average or higher to be able to do the PCR amplification without some fancy nested PCR approaches and that type of thing. So typically what you do is really, if it's dropped below 500, heck, at that point I'd say we got success. I'm not going to worry about it any further. Move on. Congratulate the patient on taking medicine. They'll almost certainly go down to toward an undetectable level, and you're done. Okay, I think that's it. Thank you for hanging in there with me. We got about a 15-minute break. Remember, you got to go back to the room where it happens, the big one. And I've really enjoyed being with you. I'm really sorry that we're doing this by Zoom because it's kind of hard to connect, I think. I mean, you can see me, but I can't see you as well. And I like to have that interaction, especially in a breakout. But you guys did a great job keeping up with this. Please send in your evaluations. Let me know what you liked, what you didn't like, what you think I could have done a little better. And we'll go ahead and end the session. Thank you again for being with us.